Hello, I'm Dr. Baiju. I'm presently working as additional professor of cardiology in Government UD Medical College, Alapura. I'm interested in interventional cardiology and more towards preventive cardiology. So I would like to update you on the what is latest in hypertension. So as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to the cardiovascular disease, which affects 45% of people in the age group of 40 to 69. The raised blood pressure is among the most important risk factors of cardiovascular disease. Moreover, it remains poorly controlled due to the low awareness about hypertension, the lack of appropriate care through the primary care, and poor follow up. So in India, the prevalence has gone up over 30 years to 38% in men and 32% in women from a previous 29% and 28% respectively. This is a WHO data. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, are unaware of this condition. Additionally, over 62% of men and more than 53% of women living with hypertension did not get treatment. Medications were used to control the blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. So, International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. So, the inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refer to the minimum standards of care to allow specification of essential standards of care for low resource settings. So they have clarified and stressed on the low resource settings and what to do. Now the ACC-AHA has released a scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among the low risk adults, the adults with no atherosclerotic cardiovascular disease or a 10-year cardiovascular disease risk less than 10% with stage 1 hypertension, that is a blood pressure of 130 to 139 systolic, 80 to 89 millimeters diastolic. The management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Another important area is acute respiratory distress syndrome. It's a potentially fatal condition involving lung damage and experts often associate with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce the lung inflammation and improve the respiratory function in people with COVID-19 induced ARDS. The lowering the systolic blood pressure charges down to 110 to less than 130 millimeters range substantially reduced the cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150 millimeters of mercury. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on Management of Arterial Hypertension recommends that the diagnosis of hypertension should not only be dependent on an office blood pressure measurement, but also on the out of office measurements such as ABPM or home blood pressure monitoring. The 24-hour and nighttime blood pressure measurements were associated with greater risk of mortality and composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurements for estimating the cardiovascular risk. For every 20 systolic and 10 millimeter diastolic increment of blood pressure, which is measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by a huge 36%. Most patients with hypertension require lifelong medical therapy to achieve the optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence to treatment, The importance of combination treatment is particularly highlighted to improve the adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend that, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or ARB with a calcium channel blocker or diuretic. Since early July 2018, the products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitroso-dimethylamine, that is NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. This NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 100,000 patients would have received NDMA-contained valsartan from Xinjiang, Huai, that is the manufacturing site where the highest levels of contaminants were found every day for 60 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 100,000 patients if they are taken the highest daily dose over 4 years. The valsartan recall accompanied by a significant increase in the rate of emergency department visits of around 6%. We have the HYGEA study, which represents the largest study that tested nighttime antihypertensive treatment. In this trial, the chronotherapy was associated with a significant reduction in endpoints, that is, including the death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, around 1,752 participants experienced the primary cardiovascular outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how BP differed during sleep. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. So these are the points which I would like to highlight in the recent updates regarding the management of hypertension. Thank you.